I'm reflecting a lot on what I'm going to be talking about today, and in some respects, in a sense, the what next question has already been answered by a lot of the things that people have been already talking about. But there's some important things I want to come to towards the end, and really focus on this notion that really it's a question of scale that we have an issue with. So before I begin, though, I'd just like to acknowledge I'm about 100 metres from this special place on Wurundjeri land. And I'd like to acknowledge the fantastic custodianship of this great place that the local Indigenous people engage in, and acknowledge their elders past, present and emerging. Quick disclosures: I have received some investigator-driven funding from Gilead for hepatitis C, and an untied educational grant from Indivior that went paid to the National Drug and Alcohol Research Centre that I was involved with. And I've been an unpaid reward for an intramuscular naloxone product, but I don't think any of those things impact on what I'll be talking about today. So three key things about opioid overdose. It's obviously a major public health problem. I'll talk a little bit about some figures related to that. We know that opioid overdose deaths are preventable. There's obvious initiatives that people have been talking about today, right through to what Sione and Rick have spoken about just now. And those interventions are available to prevent overdose deaths. Sorry, just didn't click through. And I want to just quickly introduce this guy, Campbell Aitken. He's a dear friend and colleague who a few years ago asked me this question when we were at work. And he basically said, we've spent all of this money on the problem of hepatitis C. Why haven't we solved it? And, it was it was a really challenging question. And then not long after that, we started seeing the results of the new treatments for hepatitis C that basically, had incredible results, and essentially, revolutionized the way in which we approach this question. And it really does raise the possibility of all sorts of new approaches. Because they're effective, tolerable, they have a short duration, they're simple to take. You can see from Rick's presentation before, they can be integrated into other types of services that people might engage in. And so ultimately we can contemplate eliminating hepatitis C. Now, eliminating hepatitis C is a fantastic thing. We're going to hear a lot about that at this conference. But the fundamental thing is, we really haven't had that same thought or approach in relation to opioid overdose, and it relates to some of the issues that Alison was raising before about we haven't really agreed what the problem is, and I'll come exactly to talk about that in a minute with some relatively high-profile quotes. But I guess the promise of the hepatitis C framing really does, I think, link into where we should be heading with opioid overdose. The current situation is dire. So basically, there's estimates in 2017 of about 115,000 people dying of opioid overdose across the globe. Those estimates are very heavily driven by the issues in developed countries, and that's partly because we have terrible measurement of what's going on in low and middle income countries. Lots of anecdotal stories about ways in which we would never find out about people who are dying from opioid overdose in countries like Myanmar and so on. So I think those estimates are very rubbery at best. And the US situation we talk about a lot, and political actors do engage with it frequently. So basically, these are sort of random quotes from Donald Trump, which obviously lots of people have issues with Donald Trump, but he certainly did articulate recognition of an opioid overdose crisis, and basically highlighting investment in resources that we have heard from various people in chats and so forth, that there's lots of money going into these things, but really things haven't turned around. Except in 2018, the White House they turned around opioid overdose deaths because the numbers went down a little. We have to fight the drug epidemic and help get treatment for those in need and so on. But basically there's never been a high-level articulation of support for harm reduction from people like the US president. And here is the reality of the situation, though. I mean, we see there was this small decline there for a while, but things have since gotten worse. And when Alison was talking about the killer graph, this is literally the killer graph because it does reflect death, but also it does reflect something that's driven people to action, people such as Donald Trump, to actually invest resources. The problem is, I don't think the investment is appropriate, or we haven't seen the sorts of things that we need undertaken. But it continues beyond sort of demagogues like Trump. I'll skip that slide. This is what the Biden administration has just funded, and this has just come out recently. And basically, historic levels of funding prevent and treat addiction and overdose. And if you look through the catalogue of the initiative will fund, expanding access to evidence-based treatment and so on, racial equity issues, which I think is really important. Evidence-based harm reduction efforts are listed there very clearly. So, presumably that means they'll open a series of injecting rooms across the US. And then a whole lot of other things that are just continuing previous efforts. So, clearly the killer graph is there. It's producing investment, but I think the mix of investment, which I did have a slide for, but I won't go to for time, is inappropriately balanced. But we in Australia, we don't talk about the public health emergency anymore. We don't talk about crisis or anything. And when we were talking about this yesterday in the Newer Forum, I think we actually need to start articulating things in this frame. So I changed the title of this slide to now have the word crisis in it, because, okay, the figures of opioid deaths in the late 1990s were extreme in the Australian context. But basically, right through this period, there's a large number of people who've passed away unnecessarily because we have interventions, we have approaches that can prevent these things. And so I think we should be regarding this as a crisis, and we should be using the crisis terminology when we're talking to policymakers and practitioners as well. We need to really reduce that. And luckily in Australia, it doesn't look like we have had the increase that the US saw in COVID-19. So these are the sort of most recently available data I was able to find, and they're from the Victorian Coroner's Prevention Unit. And basically showing that in 2020, we didn't have the increase in overdose deaths that we saw in the US, but we did have basically something that's pretty stable from 2017 onwards. So still completely and utterly tragic, and still, in my view, a crisis. In spite of the lockdown that happened in 2020 in Melbourne, where a large number of deaths normally occur. And you can see that really it's still being driven just as much by illegal drugs like heroin. That's what most of these overdose deaths relate to, as much as pharmaceutical. We need to be focusing on that. And we really need to have a conversation about fentanyl. It's a real puzzle that we don't have fentanyl in Australia, and we need to be upscaling now and ramping things up now to prepare for fentanyl. And also think about what it means around fentanyl. And I'm really keen to have consumer perspectives on fentanyl. We know that people are seeking fentanyl as a drug of choice nowadays in North America. And what does that mean for us in Australia, where we don't have it yet? But anyway, so I'm going to turn to the catalogue of interventions that we have here in Australia. So ultimately, we care, which I think has a fundamental impact and drivers of our lower death rate. And we have things like harm reduction. We have treatment for bloodborne viral infections. We have drug and other treatment options that other people are talking to, and obviously long-acting injectable buprenorphine has a potential to revolutionise a lot of the things that we do. We have a very effective first responder system. We have supposedly discretionary law enforcement. I'd love to talk about some of COVID impacts if I get a chance, maybe during Q&A, about how law enforcement actually proceeds. We have education strategies underway. We have now take-home naloxone. This is a relatively recent innovation of about 10 years now. And we also have a couple of supervised injecting facilities. But we also have primary care for key populations. Now, that catalogue doesn't look all that different to what's available in a lot of other jurisdictions. But the key problem is our coverage is inadequate. And I want to now just quickly look at what, from our supermix cohort of people who inject drugs, how well these interventions are actually being taken up. So if we look at opioid agonist treatment, only 67% of the cohort have ever been on opioid agonist treatment over the 10 years of the cohort running. Now, so that means there's 33% who haven't. So we can't just think of opioid agonist treatment as a silver bullet that's going to solve all. And those 67% of people who have had opioid agonist treatment may well not have had that treatment for very long, and they might have had poor experiences in terms of the way that they've engaged with that, given dispensing fees and so on. So there's lots of room for improvement about what we do with opioid agonist treatment, even before considering long-acting injectable buprenorphine. Only 58% of people have taken up the opportunity to engage in take-home naloxone programs since 2019. So there's obviously a group of people who aren't necessarily willing to engage with take-home naloxone. So we also need to be thinking through how we actually work to make sure that those people are safe as well. Supervised injecting facilities. So basically we've had one operating in Richmond when we've been interviewing people since that facility opened. Even people who live and are recruited in Richmond, and there's still 16% of those people aren't able to use the facility. That might be because they're not allowed to use the facility, or the whole range of different reasons that might underpin that. And across the cohort, 32% are only accessing it. So that one facility can't be the panacea for what's going on. And primary care for key populations, 33% of people are attending GPs every month, but only 5% in the past month were attending those primary care centres. So this coverage is incomplete even with our universal healthcare. And so we need to be engaging in the sorts of strategies that we've had articulated by Sione and others to ensure that these things are in reach. But some of these things kind of crawl along, and it takes a long time for things to change. And Alison's made that point in the drug sphere. So in 2013, the UNODC and WHO started talking about take-home naloxone and overdose response. And you can see the kinds of points that they came up with about reducing availability, providing effective treatment in prisons, effective treatment of opioid overdose, which brings in naloxone for the first time. We're seeing this catalogue of things being listed, and it's just a question of how well they're being implemented. Basically, in 2012, they started talking about preventing overdose in particular. In 2016, we started seeing the emergence of take-home naloxone as a principle guiding practice in relation to opioid overdose. And in 2014, I was involved with a group who pulled together the WHO guidelines in relation to community management of overdose that included take-home naloxone for the first time. And ultimately, the WHO has come up with these targets of 90-90-90. So 90% have received training, 90% have been given an emergency supply of naloxone, and 90% will carry it or have it close at hand. I can't imagine there's any jurisdiction that's anywhere near reaching those kinds of targets, with the possible exception of Canada, or parts of Canada maybe. So we really do have a long way to go. And importantly, we have a long way to go in jurisdictions that we don't generally talk about. So we've seen a little bit of work, people speaking about, Zoe was talking about Kazakhstan and Central and Eastern Europe, and Eastern Europe and Central Asia. And I was fortunate enough to be involved in this SOS study, which I'll be talking a bit about later on. But fundamentally, we showed in this study that we're able to rapidly scale up take-home naloxone in this jurisdiction where the first responders are not great. So basically, you might not get an ambulance coming in time. The ambulance might not have naloxone on board. The ambulance might not want to respond to someone who might have had an opioid overdose. So, but we were able to train 14,000 witnesses in 3 months, which is quite an incredible achievement, given that it was really a demonstration/pilot program. So basically, we saw the implementation in those countries is incomplete. And in a country like Australia, with universal healthcare, the implementation is really patchy. So you can see these are all the sorts of things you would want in relation to take-home naloxone. So peer training, online training, all sorts of things like proper Good Samaritan protections. And you can see really it's very patchy, with some jurisdictions like WA and New South Wales doing better than others. WA in particular because of some amazing advocacy by key stakeholders over there. But the situation is really quite patchy. And ultimately, even in this context of universal healthcare, there are all of these problems. So we have, we now have intranasal naloxone, which is fantastic, but should have been available for a long time. We don't have consistent legislation. We don't have national coordination, distribution targets, or anything like that. Key risk periods like point of custodial release, so when people are released from prison or other forms of custody, we really don't have good coverage at all yet, except New South Wales, and there are initiatives in place. And we don't have consistent programs for pharmacists or primary care. This issue of scale, we really are lacking scale in even in the context of a rich country like Australia. People will be familiar with, a lot of people will be familiar with this shop front from Sydney, which is the medically supervised injecting centre. It opened in 2001. Evidence accrued about its effectiveness was collected very soon after that showed it was effective. Yet it's still the only injecting facility available in Sydney. We finally got movement in relation to that injecting room in Melbourne in 2018, and the Melbourne injecting room opened in a small facility here, ultimately superseded by this larger facility that was built shortly thereafter. We've seen how uptake of the Melbourne facility has been really fantastic, and the new facility opened, and you can see that uptake is now around about 330 visits per day, which is pretty amazing. And we've shown in a paper from our cohort study Supermix that the people who are accessing the facility, I won't go into this very dense table, but the people who are accessing the facility are the most marginalised and vulnerable, so more likely to be living in homeless conditions and so on, more likely to have experienced incarceration and so on. So key things, the facility is actually working to bring in the most vulnerable. We've shown that people who use the facility frequently, their overdose numbers go down in terms of being attended by ambulance. It seems like a pretty obvious sort of thing, that if you're in a facility that you won't have an ambulance attend there because you'll be resuscitated in the facility and so on. But this was this kind of information was pivotal in terms of providing rationale for keeping the facility going. And there's other compelling evidence around ambulance attendance data too, which is all consistent with the supervised injecting facility data worldwide. But ultimately, there's really only one country that has widespread systematic implementation of supervised injecting facilities, and that's Canada. And there's still problems with the way in which they're implemented there too. We heard yesterday about how one in Ontario closed its doors during the first month of the COVID pandemic, which basically means that people were unable to access a safe place to inject during that period, which is totally unacceptable. But what's the political football that we have in relation to a lot of these initiatives is, I think, most starkly illustrated by the move to open a second facility in Victoria, which is ultimately, I think we should take our hats off to the government for basically ploughing ahead with this recommendation that came from the review, to actually not just have the North Richmond one, but to establish a new one as well. And so this is Flinders Street, Hosier Lane. It's a tourist attraction. It's a place where there's already primary care for people who inject drugs just around the corner there. And so lots of people who use this laneway are citizens who inject drugs, and they fit completely into. There's no. Basically, it's just a part of the community, as you would expect. There's massive controversy about the idea of opening an injecting facility just near this, in spite of the fact this is a place where people do hang out. And basically, here's Hosier Lane somewhere up here, and this building on Flinders Street is just here. So it's only a couple of 100 meters away. And yet there's this incredible controversy about opening a facility, in spite of the fact that this is a place where people frequent and have every right to be there. So we have this incredible football in Australia where people inject drugs bear the brunt of. But ultimately, we need to be also actively exploring new interventions, and we still need to learn a lot about how to respond to overdose. And my colleague Mary Harrod pointed out yesterday the new smartphone apps that have been developed that help in spotting, so people where people can look after one another, so they send warnings if people aren't heard from and so on, as an overdose prevention thing. So these are the sort of behavioural things that people are engaging in, using some smart new technologies. But the other new technologies really need to be pursued as well. And I kind of started thinking about these things with Nico Clark some 5 or 6 years ago, and we expected that big tech companies would be building on this, given the crisis in the US. But really, there hasn't been enough movement in that regard. So, basically, we know that overdose is related to low oxygen saturation. So we must be able to monitor that somehow in a way, and link that to normal variations in saturation. And the things we were talking about was wearable monitoring, and it seemed like those sorts of things were going to be pursued in the US. And there's been a little bit of work in that regard. So some of these dummy devices, there's been some acceptability studies of that, but ultimately you want something that ends up just looking like a Fitbit rather than something like these kinds of cumbersome devices, or a very smart smartwatch that can do all sorts of things, like even to the point of being able to administer an antidote if that's required. But ultimately, we've heard some stuff around safe supply, and it was great to hear from Matt about his experience of the work that's going on in Vancouver at the moment about essentially a form of civil disobedience, but essentially trying to create a appropriate self-supply, a safe supply for people that takes it beyond just the medical model of a dispensing machine and so on, which is still still an incredible advance, but the work that's going on in that Van Du and others are leading in Vancouver and in partnership. There's the traditional partnerships of researchers and peers in Vancouver really are pushing the envelope, and we really should be looking for them for leadership in how we might approach that kind of work. So ultimately, we need a major scale-up of all overdose prevention interventions. We need to be thinking through how we actually respond to people who use alone and might use at home. We haven't nailed that at all, and we aren't doing enough to support those who don't inject drugs. And it's all connected to these factors that other people are much better qualified to talk about than I. But we need to be addressing them. Safe supply, I think, has real promise, and also I think we really need to be pursuing these new interventions. I'd just like to acknowledge the Burnet fieldwork team and the Supermix collaborators for some of the data that I presented here, and then Mary Ellen and Amanda as well. Thank you very much for listening.